Firstly, we're going to have an ad hoc speaker, Rob Blagden, who's here at the University of Gloucestershire, who's the Director of Libraries and Technologies. I hope that's right. So the floor is yours, Rob. Thank you so much.
Thank you. Great. Well, I offered to cover if Joe didn't manage to get through on his connectivity from somewhere in deepest, darkest Turkey, or probably lovely and sunny, I'm sure. But I am not Joe, and I don't propose to be able to fill his boots. But I am a Gloucestershire patient, have a real interest in digital, was on the first cohort of NHS Digital Academy, and now I get to mark a range of student papers on digital innovation on that master's programme, which is fascinating to read. All of these great new ideas, all these great thoughts that people have about how we could improve health and care using digital is just a fascinating read each summer as I do those. How are we getting on? So this is a presentation I did April, I think, can't remember, for Scotland Government. They were looking to introduce a digital leadership programme across not just health, but also across government to try and join up care in a new way where all providers were involved. But so I was a sufferer of polycystic kidney disease. Both my kidneys got really big with cysts, had them removed, did a year with no kidneys, which I don't recommend. I've got a big fat arm from my dialysis days, but had an interesting time as a patient, particularly when I know what's possible, having been working in the NHS in Gloucestershire for the period I was ill. So this is kind of my diagnosis. It took them about 5 years to diagnose me. And I'm just thinking, couldn't something digital have checked Rob's blood pressure wasn't being managed for 5 years and done something different to try and address the underlying cause? What eventually happened is I moved GP, and they said, "Have you had a kidney scan?" I was like, "No, kidney scan? What do you mean?" "Well, you should have had a kidney scan by now." And as soon as they did that, they worked out I had polycystic kidney disease. Sure, digital could have helped us there. And then the preceding sort of 5 or 6 years, my health deteriorated. Kidneys got worse and worse. Had them removed, had various appointments. The pain that is taking family members through assessment to see if they can donate to you. 5 times we gave up in the end. Took about 3 or 4 months per person, and they have to trundle all the way to Bristol and back. So that never really worked. So we waited for transplant. This is me on dialysis. So I was in the unit, my wife was coming in with me, and she said, "I could do this." And they said, "Well, you can go home if you want." So we arranged to go home, at which point the hospital said their contract with Fresenius was ending, and they were in an interim period, so they couldn't do that. So we waited another year, but eventually got home and meant we had a lot more family time, which was fantastic. And we still went on holiday. Even when I had no kidneys, the NHS was great, and we got away, spent most of my life in a hospital while I was there, but the family got away with us, and we had a fantastic time. So this is me and my data. Colleague up there talked about can't we get our data? Can't we have access to our data? So I got the data from what was patient view. I will rant about that shortly. And you can see on the graph, I plotted, and the red mark was where I was once I got my data. And my kidney doctor in Gloucester, amazing chap, love him, said, "You've got 10 years, Rob, go and enjoy your life." I said, "I think I've got a couple of years." "Rob, you can't be right." I said, "Well, the data's saying I'm losing between 1.5% and 2% function every month. Therefore, kidney failure is only 2 years away." He said, "I'm sure you're not right, Rob. Go and enjoy your life." And within a year, I think I was on dialysis. So this is my rant, if you want a rant. This is patient view. It's a beautiful system. Used to be called renal patient view for renal patients. 8 o'clock in the evening, if I've had a blood test in the morning, all my results are there. Really easy to see. You get there, this is all the latest stuff. You can see what it is. You can go and view a chart. You can get information about what your ranges should be. But the NHS, in its infinite wisdom, upgraded us and migrated us over to this monstrosity, which is patients know best. But if patients know best, they would have stuck with this. Because, can you read that? And some of the data on there, there's one somewhere, I don't know if it's on that screen, it's 2 to the 10 to the something or other. Terrible decision. that will cause patients to disengage with managing their own care. But we do have a single system across the NHS for patients and blood results now. Fantastic, it's just no one will use it. I know I haven't got long, so I don't want to talk too much. But this is kind of the people side to the condition. So I had this ultrasound that the doctor said in 2008, why haven't you had one? So I go in on a Saturday morning, they bend over backwards, can't do enough for me, really friendly, supportive, tell me what's going on, show me the screen. And I walked out thinking, that's okay, you know, they're going to look after me, they said I'm in the right place, better to know than not know. Counter that with what happened in 2019, 4 years after transplant. I was more confident going in, I was less nervous about what they were going to find. But I was treated poorly, it was very unfriendly, the welcome. They ignored my wife behind me. And then they treated me as a cadaver, really, for training, and trotted through a whole load of trainee doctors to see this interesting kidney that's in the front of me rather than in the back. And it left me feeling annoyed rather than content and happy that I was well. It's a weird one. Yeah, there's my kidney, blah, blah, blah. Got really, really ill, couldn't have... Should have warned you about that, sorry. Couldn't get my kidney removed for about 3 months, and I was so ill with sepsis and blood in my urine continually that my lovely stepdaughter raised £8,000 in 2 days, and then I went into Gloucester, and they were quite happy to have me when I was paying. Then we had the other kidney out. Loads of problems where people just didn't listen to me as a patient who knows my condition, so I lost loads of blood several times. After they took one of my kidneys out, they wanted to come and give me a transplant, and I was just coming round. And as I was waking up, this junior doctor was going to give you some blood. I said, don't give me blood. Unless I'm going to die, don't give me blood, because that reduces my transplant options. And they didn't understand about all the cross-matching and the bloods, the antibodies. So I gave him a lesson as I was coming round. He called Bristol, and they told him not to give me blood under any circumstance. So you can see my beautiful hands. They were pretty much that colour the whole time while I had no kidneys. You know all that. But we had a lot of fun when I came out of hospital. I even carried my kidney in to the operating theatre because I nearly lost it. And we celebrate every year, blah, blah, blah. So my kidney could fail at any time. I wouldn't be able to work. My wife doesn't work already and can't work. We would be shot, and I don't know what we'd do. But I can't live life worrying about the future. I want to plan for the future. I want to assume the best. I want to hope for the future. So we spent a fortune, knocked the house down, and rebuilt it, which we're really glad we did, and we're still paying for. But that's all right, I'm still working. Biggest problem that always gets me when I do this talk is my kids, because both my kids have got it. My daughter doesn't want to be tested, but we think she's got it. My son's got massive cysts already. He's only 23. And I feel guilty, not that it's my fault, but it's an inherited issue. Anyway, we won't stop there because I'll be in tears. I really whizzed through this because I needed to. But my top tips for you are be real with me about what's happening. I want to know. Some patients might not want to know. Maybe find out what your patients want and then tell them if they want to know. I'm happy when I've got my data, please. Please give me my data. And please get rid of the rubbish system you've given me. Changing digital systems without consultation is likely to result in disengagement. And that's what we've done at the moment, which is really sad. And how people interact with me is pretty important. And put your people before the technology. Because if you talk to patients about the system we were going to change, the patients would have told you, please don't do that to me. But we thought we'd save some money, which was a shame. This probably doesn't relate, but you can all make an impact. And you are making an impact, I'm sure. But please support positive digital decisions if you get the chance to, because it'll make the difference to me as a patient and to lots of people. Thank you very much.
Wow, thank you, Rob. I'm not quite sure how we follow that, but I mean, sets the scene beautifully for this next session. So thanks so much for sharing that story and thinking of Jake and your daughter. Next, we have Matimba Swarma. And I just want to get her bio right because she is a rising star to me. She's a PhD candidate in the Department of Engineering Mathematics at Bristol University. And when I first heard her speak and saw the project that she was doing, as a cancer oncologist who's seen the evolution of cancer treatments, I was like, oh wow. I really haven't been horizon scanning because I didn't know about this, and I'm going to let you introduce your topic. And not surprisingly, Matimba has been snapped up by the Futures team in the UK Government Office for Science, and I'm just thrilled that they got you and really interested to hear what you're learning, and we talked a bit about that. You're also on the Bristol University Cancer Steering Committee, where I have the privilege of working with you, and on the executive board of the Brain Tumour Charity, huge unmet needing future treatments and things. And you previously worked in stem cell research and clinical trials, so bring a wealth of experience into this technology that, for those of you who were in the 70s, really makes me think of that film where they used to shrunk the people and they went inside a body. Was it? Fantastic Voyage, yeah. So, Matimba, the floor is yours. Can't wait to hear what you're going to tell us, and thanks for joining us today.
So this isn't science fiction, but I need to watch Fantastic Voyage. I haven't seen it. So just quickly, cancer occurs when abnormal cells in the body divide in an uncontrolled way, and traditional chemotherapy is systemic, so it targets both the cancer cells and the healthy cells. And cancer nanomedicine is the medical application of nanotechnology to treat cancer. Nanoparticles are about 1 to 100 nanometers. So this 1 nanometer is the equivalent of what a tennis ball is to the Earth. So to put this into context of the human body, red blood cell is about 7,000 nanometers wide. And chemotherapy is quite a passive treatment, and nanoparticles can aid in the delivery of chemotherapy, even though it's a lot better. There's still issues with clinical translation being quite low, and so we can use a systems approach to aid in clinical translation. So in silico models, these are computational models, so experimentation using computational models to select nanoparticle design based on size, shape, loading, coating. But rather than just looking at individual nanoparticles, we can look at how all the nanoparticles interact with each other in their environment. So looking at a collective system rather than the individual. And in research and development now, researchers are looking at nanorobots, which can control their motion and interaction with their environment, so a much more active nanoparticle treatment. And what I'm looking at is nanoswarms. So nanoswarms are nanoparticles or nanorobots that can interact with each other and their environment to target, complete a collective task, such as target a cancer cell, and these are inspired by swarm behavior. So when we're looking at micro nanorobots, they could eradicate cancer in 3 different ways. So carry and deliver and release a drug in a tumor, similar to current nanocarriers. Indirectly eradicate a tumor by activating or stimulating the immune system, similar to immunotherapies, or mechanically kill a tumor and induce tumor cell death. And when we're looking at these collective nanomedicine systems, like nanoswarms, they could do things individual nanorobots cannot do. And that includes things like spatial organization. So this can lead to like a higher tolerance to transport and biological barriers because of things like pattern formation and aggregation, navigation as well. So this is adaptability to complex environments and dynamic environments, such as the body with different speeds of blood flows, different environments when moving across biological barriers. Decision making, so having information about the state of the tumor and change the behavior to release the drug. So the tumor microenvironment is very different. It's hypoxic, different temperatures, different pHs and different pressures. And we also need to think about clinical translation. So things like the mechanism and mode of action. So is this injected? Is this taken as a tablet? Is it a wearable? Human nanoswarm patient interaction and regulation as well. So we're moving away from these nanoparticles to a much more active and collective treatment. And nanoswarms, microswarms, and macroswarms, so a lot of different types of swarms. When we look at swarm robotics, a lot of people think about big robotic systems or drones, and there are similarities when we're looking at the nanoscale. So this is coordination of a lot of simple agents, but there are also differences in terms of size, so different challenges, and numbers. So when you're looking at swarm robotics, it's more in the hundreds and thousands. When we're looking at the nanoscale, it's more in the millions and trillions. Power supply, so when you're looking at swarm robotics, the battery powered, unlike on the nanoscale, you're looking at using like heat, light, magnetic fields, electric fields. The healthcare system at the moment is underusing digital technology, and one of the reasons is because there is no governance or framework in place, and there's little regulatory guidance at the moment and no agreement with the current nanoparticles that we have in the clinic. So it's unclear what the regulations would be for nanorobots and nanoswarms. When we're looking at kind of future developments and where we want to take nanoswarms, we take inspiration from swarms in nature, so birds, bees, ants, fish. And when I was talking about spatial organization, this can be broken down into different areas. Things like aggregation, where you could have positive like kind of reinforcement, where you can have the number of agents amplifying once they're at the target site, or negative reinforcement, where they actually decrease the number of agents, as well as navigation, which also has different examples here. So one is coordinated motion, so moving against blood flow, and decision making, so regulating group size and collective fault detection. And then you have to think about the clinical translation side, which is the mode, mechanism of action, and the interaction with humans. And using kind of a futures approach, which I've taken from the futures team that I'm working with, is thinking about the many possible alternatives and futures that could arise based on historical evidence, trends, and present possibilities for change. And there is this like kind of dual use dilemma with this technology, where one and the same piece of technology has the possibility for all these benefits, but also for harm too. Looking at a regulatory framework would involve looking at all these like different things, which also include stakeholders. So one thing that I've done is a qualitative study looking at how should we regulate nanoswarm cancer therapies in clinical trials, and talking to healthcare professionals working in oncology, oncology patients, nanomedicine researchers and developers, as well as policy makers too. Did 21 semi-structured interviews at the moment. This is an ongoing study, and 5 themes have emerged from the interviews, including kind of the patient cancer journey. There is kind of a skew when it comes to the patient cancer journey. That's talked about a lot more with patients and healthcare professionals, a lot less actually with regulators and developers. Perceptions as well, so people's perceptions of nanotechnology, artificial intelligence, machine learning. Regulation, the kind of current regulation that we have in place at the moment and what we would need in the future thinking, so people drawing on what has happened with the COVID pandemic and lessons learned and what we would need in the future, and stakeholder interaction. So some of the things that have come out of this is, you know, there's been a quite positive response with it being really revolutionary. It's really unclear who will control nanomedicine, and a lot of people would want to know what is the worst that's going to happen, especially from the healthcare point of view. If I injected a patient with nanoswarms, would they go into cardiac arrest, is one of the things someone asked me. And then if patients can't trust research, then they won't want to get involved in it. They won't trust the answer that research gives them. And no one wants to be a guinea pig, so no one wants to be a test subject. And when it comes to a lot of the patients that I talk to, cancer patients tend to be a little bit older, and they drew on popular culture from, I guess, like Fantastic Voyager and other films. Like, I guess some people were talking about Star Trek and Terminator and all these things, which was very different from when I did a public engagement event with kids, and they have never seen any of these films like The Matrix or anything, so they did not have the same question. But you know, this like idea of giving up our autonomy to artificial intelligence was very much at the forefront of some of the patients' minds. And the kind of technology, this kind of technology works differently in different countries. So maybe it would be regulated as a drug or a device in one country and then something else in another country, and how this impacts how it's regulated. And there was a lot of talk about collaboration, especially between academia and healthcare professionals, and people feeling quite hopeful, which was good. So there was a willingness to develop nanoswarm treatments, which was quite a nice relief. And there was also concerns from all stakeholders about trust and transparency, in particular with patients, actually. And so one of the future things is looking at knowledge, and how do we build knowledge and expertise in policy makers and also in healthcare professionals, and stakeholder collaboration. So even though the healthcare professionals are a lot closer to the patients, how do we also have that connection with academics and nanomedicine developers and patients too. Governance as well, so can we build on existing processes or create new ones with something that's going to be evolving and changing. So I'm actually just going to finish there because I think I've run out of time, but thank you very much for listening.
That's absolutely fantastic. Yeah, I'm blown away by that. When do you think the first trial in man might be? Will it be in my lifetime as an oncologist?
I think it will be in your lifetime, but it depends. It depends. Like, this trust thing is a huge thing, so yeah. I don't know.
Yeah, but at least you're asking those questions and engaging that early. Well, we'll come to questions later, but I mean, that was just fantastic. Sophie, please come on down, as they say. Sophie is an NHS clinician who created Lister. And that was around some of the frustrations that we've been hearing about this morning. And you were sort of recognising that you wanted to work better and prioritise patients and their care, and also patient safety. And also you felt that there was a lack of transparency between tasks and staff members, with various roles being different from what we thought we were meant to be doing and meant to be delivering. So you started thinking about how we could solve this, and that's exactly the sort of innovation that we need in our clinical workforce. And unsurprisingly, you were accepted onto the NHS Clinical Entrepreneur Programme in 2019, and your idea was about digitising the process to improve patient safety, teamwork and workflow, which I think for the clinicians in the room is absolutely fundamental to our life. So over to you, and thanks so much for joining us, Sophie.
Yeah, no, thank you very much. I've never seen myself so big before, so I was a little bit taken away by that, but here we go. So yeah, thank you all for allowing me to speak today. So my first slide is my longest slide. It's my introduction, because it's my clinical background that's essentially led me here today. So I'm a midwife by background, still am. I still work clinically. And it was my experiences working on, the clinical shop floor that led to various frustrations that essentially I wanted to try and solve. I could probably list a lot, but for some context, the amount of paperwork I needed to do after delivery, which was very conflicting with the time that I wanted to spend and should be spending with new mothers and new fathers. Trying to make sure my handwriting was illegible on blood tests, which if I get wrong could be critical. Having fun with fax machines, I think many of you relate to that, and faulty equipment, the list really goes on. So I trained as a midwife in 2014, almost 10 years ago, but I was somewhat equipped to what it meant to be a midwife. So I was trained to deal with emergency scenarios. The bit that I wasn't mentally prepared for, or was really unknown to, were the non-clinical frustrations that I experienced. And they may seem really small, but they really greatly and negatively impact my workflow. So I then decided that I was going to spend my whole career making the NHS more efficient and more safe. So I'm now an improvement advisor at Homerton. I'm based in London, so I work there 3 days a week. And on my other 2+ days, I'm an NHS clinical entrepreneur, which is a national programme for clinicians who want to innovate in the NHS, led by NHS England. I'm an innovation fellow at Mid and South Essex. We're a pilot in Lister, and I'm a co-founder of Lister, which is what I'm going to talk about today. I also sit on the National Digital Shared Decision-Making Council with NHS England and the London region, and in my spare time, I'm a master's student in digital health and entrepreneurship at UCL. So I mentioned some of the pain points I experienced as a midwife, but this one was my favourite. So what you can see on the screen, and if you can't see it, don't worry, because I can't see it when I'm working either, is something called a paper handover sheet. So you would log on to an Excel or Word document, you would print that up, enter the patient's details outside of the EPR or patient notes, you would print it off and you would scribble on it as a way of remembering who requires what when by who for a whole 12 hours. I did a survey, maybe I'm the only person who does this, I'm not. It was my survey, but of those who answered, which was around 100 clinicians, over 85% of clinicians still use these as their main method for task management. Digital maturity or EPR status didn't seem to have too much of an effect. So why is this a problem? What does it mean to me? And I'm going to say, what does this mean to me? But I've spoken with about 100 clinicians, and the problems are very much the same. So it means that I waste my time. So I spend around 30 to 60 minutes for each clinician, each shift, just managing and prepping these paper lists. That's not to mention the amount of time that I spend searching for it when I misplace it. And they're a significant threat to patient safety. So for context, we have around 120 tasks per 12-hour shift for each clinician. When you bring in the human factors, you can only remember 5 to 6 pieces of information. So just imagine the cognitive burden that sits and trying to remember all of those tasks. I did forget, I've forgotten tasks before, and then I feel awful about it. So one example, and this is just one example, I forgot to do a blood gas for my lady who was high risk and was hypovolemic. That was abnormal. She had high potassium levels and she went to ITU. And I could have dealt with that a lot sooner. Missed opportunity in obtaining the task list data, that's kind of another topic. There's a lot to it, but I do feel like if we had a number of tasks per staff and per patient, we could effectively resource better. And the avoidable cognitive stress, I've already mentioned it. So this information really does sit in your head because I don't have the effective resources for me to do my job properly. How do I prioritize that piece of paper that's illegible 6 hours into my shift? And it's unsustainable. We print about 30 pieces of paper for per ward. So if you scale that, that's a lot of wasted paper. So I felt confident for whatever reason quite a few years ago now, and I decided to digitize that process. But I say digitize hesitantly. I don't mean just make it digital. I mean actually making an improvement with it. So I've spent 2 years with my team just on the design of this, because if you don't get the UX right or the human-centered design, if you don't have something that's quick and easy to use in a fast-paced clinical environment, you're going to fall at the first hurdle, and that's exactly what the other products, I believe, have done. So what am I hoping to achieve by this? Well, I want Lister to be a digital safety net for otherwise missed or delayed tasks. I want to get the data and analyse, as I stated, the number of tasks per staff member and per patient, and actually have the whole patient timeline, because right now these get put in confidential waste bins at best, so we're not obtaining that visibility. Ease of use, improving accessibility and workflow. So this is the reality. A nurse will have one paper list, a junior doctor will have another paper list, a physio will have another paper list. No one really knows what anybody's working on. Saving time, as I've mentioned, there's a big time saving here, and teamwork as well, and also reduce of data security breaches. So these lists do end up where they shouldn't. And staff satisfaction. Why should I be holding this information? Why can't a digital innovation do that for me so I can focus on my patients? So in terms of where I'm up to now, we are an investment-backed company, so I put that into building the product. We had our first NHS pilot some years ago, but the aim of that was a user-centric study. So it was just to get clinical feedback, which is great. We did lots of feedback loops. So hopefully that all had some positive effect. It shows that we really built this with the clinicians in mind. We then focused on our clinical safety case and our governance documentation, really big learning hurdle for me. And in summary, we've now got 4 hospital pilot sites. So this isn't maternity focused, this is stretched, so Liverpool, Manchester, Oxford and Essex. So the proof will be in the pudding if this is going to work. So we're in the process of our evaluation. We're integrating with one hospital system for their handover, and we're currently collecting the baseline data in another trust. Whether we can get that data enough to commercialise will be another story to tell. It's not an easy task to do in the NHS. So we shall see. So the challenges, I probably could have spent 10 minutes talking on the challenges, but because of the time, I will just talk about some of them. So the time it's taken to trial and adopt, so we are engaged with 4 hospitals, as I've said. From first conversation to now, and we're still not on the wards, has been around a year for all of those hospitals. So as I progress in my career, I would love to look at that and see how can we make innovation safe, but also speed it up. Task lists and EPRs, electric patient records, for those who don't know that, they're hospital systems. Completely sensible question for me to be asked. I tend to get it from non-clinical, so tech leads, and that's absolutely fine. Everyone's got their seat at the table, but they're not fit for purpose. They're very inaccessible, they're not user-friendly, and we don't use them, so we'll pull out a piece of paper instead. Embedding into clinical pathways and integration. I'm sure everyone knows the challenges of integration. So digital innovation should nicely and smoothly feed into our pathways. It shouldn't be an extra step that clinicians have to do. That's a challenge in itself. And of course, that does come with some level of integration, and there's unique challenges with that. However, it's fun, and I'm forever learning. So if this doesn't work, that's okay-ish, because I've learned a lot on the way. So I'm really grateful for that learning journey. And that brings me to a close. Thank you, everyone.
Thanks so much. Amazing work.
Thank you.
And I mean, maternal and perinatal health, I mean, can't be much more important things, and it comes back to our paediatric surgeon colleague about getting it right from the beginning.
Exactly.
Good luck with that.
Thank you.
Hopefully there'll be some questions about that. And then bringing this session to a close is Mr. Kareem El-Wakeel. Welcome. And you're a senior programmer with Collaboration Digital. And you're going to talk about how we can work smarter in MDTs.
That's right.
Is that right? Yeah,
that's right.
Over to you.
Exactly. Thanks, haven't even started yet, so that's a good start. So thank you very much for that intro. So we're here just to talk about our digital solution, which is how to streamline multidisciplinary team meetings, or MDTs for short. This is a subject that my father's quite passionate about, and he's been working on with MDTs and getting involved in them for the last 20 years and even running them. So he's really familiar with the whole subject, and he knows the pain points as well as what works and really what doesn't work. But he's also got a background in programming, so he has actually also created solutions across lots of different industries, from finance to medical, and for the last year he's been trying to work on how to improve and streamline these meetings, and that's how we got here effectively. So I'm just going to start by talking about what are MDT meetings for those who don't know, and what are the values that they give us. So multidisciplinary team meetings bring together healthcare professionals from different specialties so that they can collaborate together on patient care. And the idea is they share their expertise and their knowledge to deliver what's kind of considered the gold standard of cancer patient management. And by collaborating together, they can make sure that our patients should receive not only the most appropriate treatment, but also to try and bring consistency and continuity in their care, and to try and reduce the variation between treatment that's offered. Some of the hidden benefits of MDT meetings is that it's a space for educating new members of staff as well who attend these meetings. And as well as that, by sharing the workload, we actually reduce the burden on individuals taking part. And in fact, there was a study in 2009 where respondents said that, 90% of them said that actually working as part of an MDT improved their mental health, which is really important. And 81% said that it improved their job satisfaction. So it helps patients and it helps the people working on the MDTs as well. But unfortunately, there are some issues with the way MDTs are being run at the moment. Cancer Research UK did a study on the effectiveness of these MDTs, with over 3,000 people who took part in that study, and these were the key takeaways that I'm just going to try and go through for you guys. So one of the main issues is the insufficient time to discuss complex patients. Some of these meetings actually last up to 5 hours, and more than half of that time is spent discussing what is considered a simple case. And even with these long meeting times, staff members have said that there isn't always enough time to fully discuss complex cases. So we really do need to streamline these simple cases and make it easier to talk about them and get through them so that we can have a longer discourse for the complex ones. Meeting attendance is also not optimal for MDT meetings. So there are somewhere between 7 and 27 members of staff who attend these meetings. But actually, on average, only 3 people ever contribute to individual cases as they're going through the meeting, which means the other 24 members of staff are just sort of sat idly and their time isn't being used effectively. So we need to find a way to sort of make sure that clinicians know when it's appropriate for them to join and leave meetings to try and optimize their time. The next step is inadequate use of information. So the studies also showed that actually 7% of the time a case couldn't be finalized because the information wasn't available at the time of the meeting. So it has to be pushed to the next meeting. And 14% of the time, the information that is being discussed isn't actually relevant and doesn't need to be discussed at all. And eventually, when a treatment plan is offered to a patient, 15% of patients choose not to go with the recommendation because they feel like their preferences weren't taken into account. So we really do need to make sure that we have the right information available at the time of the meeting so that we can offer patients the treatments that they would like to go with. Then I mentioned sort of some of the hidden benefits, and we're finding that with the current time pressures, there's just a limitation with how much education we can do, auditing and validation of that data as well. So what impact is this having on the NHS? Well, unfortunately, there are about 375,000 people diagnosed with cancer every year currently, and that number is rising. By 2035, we're expected it to go up to almost 500,000 people diagnosed by cancer every year. And with the aging population and a number of other factors, cases are actually becoming more and more complex. So there's a higher percentage of complex cases that's going to be introduced by that year. Currently, we discuss about 1.4 million patients a year through these meetings, and it's shown there's about 20% increase year on year. So we're going to have a high number of patients, we're going to have more complex cases to discuss. So this is, yeah. So the last point, is how much money is spent on MDTs. So it is £283 million was spent on MDTs last year, so that's the cost. So that's the cost of time for all the clinicians who attend the meetings. And breast MDT alone is usually the biggest one, and that comes to about £42 million. So there's a large percentage of the NHS money going towards MDTs, and as we've outlined already, there's a lot of inefficiencies, and so there's a lot of savings that can be made there. But we are trying to propose a solution to you today, and that is actually to change the whole workflow of MDT meetings. We are building our solution on top of this study that was made to investigate the impact of having a really robust pre-meeting preparation and seeing how that affects the efficiency of MDTs. And the results were really positive, and it showed that actually a lot of the time spent was shifted from the simple cases onto the complex ones, just by preparing beforehand. So we're kind of building on top of that, but we want to make sure that everyone that takes part in these meetings, in the MDT, the whole team effectively, can play an important role in this pre-meeting preparation and make sure that they can all collaborate together so that we can make better decisions for our patients. So it starts with sort of scheduling and planning. You can use mdcoll to create templates for these meetings. And these meetings will kind of look similar to an Outlook meeting. So you kind of pick a day of the week that the meeting falls on, a time, how long the meeting's going to be, how often it recurs, and some other data. And then once you roll out that meeting, there's a calendar in the software, but you can also export that into Outlook so you can keep track of what meetings you're attending. Those meetings can then be split up into sections so that clinicians know which section of the meeting they need to attend, so they don't need to be there for the whole 5 hours. They maybe only need to attend certain sections, so it's appropriate for them to join and leave at different times. The next step is obviously patient management, so you do need to add patients to the system as well. This can be done manually with an MRN number, NHS number and so on, but we can also help you import the patient information from your hospital records. And once you've got patients, then you can start to create cases. And the cases will have this entry form that you can see, and that entry form will sort of prompt the user for just the information that's relevant and needed for the meeting. And there's also going to be data validation to make sure that all the correct data is entered as well. The next step, to try and help during the meeting to find all the relevant information, you might need to find previous case information. So there is a patient history page where you can go through all of the different cases that's happened in the past. So it's really quick and easy to do during the meeting as well. Any changes will be recorded, so you can keep track of who made the changes, when they made the changes, and what changes they made. And finally, obviously, if you do create a new case, you need to import relevant information from a previous case. That can be done as well. The last feature that we've got is reporting. So what's really good is that you can use these tools to create reports for the meetings. So you can create a whole list of, of all the cases that were discussed for that meeting. And you can create reports for patients and their previous cases. And this can be used for auditing and data validation as well. So we really do believe that these tools will help improve and make MDT meetings more efficient. And we also think that there'll be significant savings made at the same time. We looked at the way an MDT works at a hospital, and based on the current workflow and the fact that they discuss 60 patients per week, we estimated switching to just having a pre-meeting preparation set in place. You can save about £40,000 per year per meeting. But we do understand that every organisation has different workflows and different needs, and we are really keen to work with anyone who's interested in a free workshop, and we want to take part in that with you to try to understand your workflow, understand your needs, and yeah, to try and see what we can do with improving those MDTs. So yeah, this is the team. So we do have a stand as well. So if you feel free to come and talk to us if you're interested in a workshop or a demo, or if you want to learn more about MDTs. But yeah, thank you very much for your time.
Thanks so much. Thanks. How much time have we got for questions, Mark? Plenty. Got plenty. Oh, great, you're there. Can the panel join me up here? Yeah, that was fantastic. What a session. And so before we go on to the debate, let's have some questions. I mean, there's lots of things. So,
should I bring my father up?
Yeah, yeah, let's get the surgeon down. Yeah. Come on, not just sitting there. Great.
That's yours.
Yeah, great to have a father and son.
Yeah,
that's really great to see you again. Right. Any questions? Yeah. Are you waving or are you asking questions?
That's my dad. I love my dad.
Come on, Dad. Come on down.
He doesn't work with me, so
I absolutely love that.
I live locally here, so he's dropping me off. I thought, Dad, do you want to come in?
What's his name?
It's Tony.
Tony?
Yeah.
Right.
See, I do work.
Well, yeah. You must be really proud, Tony, but anyway. Right, let's have some questions. Marcus.
I can probably just shout. Can you hear me? They won't hear you online.
Online, you.
All right. Hi, I'm Marcus Bohr. I'm a GP in Yorkshire, an informatician and a software developer. So I had a question for Lister, which you mentioned something about time will tell whether you can commercialize the data or something like that. And I wanted to just drill down into what data and what do we mean by commercializing the data?
Yeah, so we're in the process of, so we're about to evaluate with 4 hospitals. So there'll be different measures that we evaluate essentially. There'll be different kind of themes that we get in terms of patient safety, the time save, staff satisfaction, we'll get some patient engagement. We need to do a study on that, economic study, just to see if it's valuable or not. I don't want to give it to the NHS if it's not valuable, but I don't know what that data is going to look like yet. So this is what I mean by time will tell. So in the next 6 to 9 months probably, I should have that data. So we'll see.
And commercialise?
Well, that would be the plans, but it very much depends. It'll be subject on the data that we get. So in my opinion, the business model should be how much you save the NHS, not just a cost that you pull from thin air. But obviously I need the data to back that up yet. So yeah, that's what I mean.
Okay. And I had one other question, if that's okay, which is about nanoswarms, which was, it mentioned in the title of, I think the study was AI-driven, but that wasn't part of the presentation. So can you explain a bit more about what the AI does, how it does that? It was part of the acronym SWARMS, the A was AI-driven.
So the different behaviors, depending on what behavior you're looking at, could use elements of machine learning, which is a subset of artificial intelligence. So, for example, with navigation, there's something that's called collective exploration, which is used in search and rescue, and drones and specific like kind of swarm drones, where you learn about the environment that you're in and the other kind of agents in that environment, as well as how the environment changes. So that adapts your behavior. So with like kind of the smoke and the fire and things like that. So.
And is that something that is actually being done or just could be done?
It's something that could be done. It hasn't been done on the nanoscale, so it's been done on the microscale. So the nanoscale is quite tricky, just because the kind of laws of like physics and thermodynamics change. But it's taking inspiration from the microscale and the kind of big swarm robotics to be able to do it on the nanoscale.
Okay, thank you.
Great question. Thanks, Marcus. Anyway, oh yeah, sorry. Can you introduce yourself as well, please? Can you just introduce yourself and where you're from, please?
Yeah, sure. Hello, everyone. My name is Kareem El-Wakeel. I'm a lecturer in computer science. I'm part of cyber and technical computing, and I'm the academic link between our university and NHS Trust.
Brilliant.
So I've got a question for you about the AI part of the AI-driven in your research. So if that will be successfully implemented, how do you think you will get control over that? Because obviously there are a lot of processing behind learning the behavior of whatever parts you are controlling, but how are you getting that control after the implementation?
So one of the reasons we want to look at regulation is to understand how much control would be okay, because the goal would be to make them like kind of fully autonomous, and you would just have like, this is the target site, get there, and you wouldn't control, like, I don't like release, like, just to make it a bit simple, so it'd be like, do not release drug in a healthy cell or impact any of the healthy cells just when you get to the target cell. How you get there, you know, maybe through the bloodstream or cell to cell, but we wouldn't control and say, this is how you move, this is where you go, this is what you do. And it's really now talking to like policymakers and healthcare professionals, like what they would be comfortable with. Would they want to have like a trigger where they want, because you can use ultrasound as well or you can like have like an imaging agent so you can track them, and would they want to have the control of releasing the drug themselves? Is that what would be acceptable? Is that what people would be comfortable with? So some of the control is really going to be about what is acceptable to regulators and healthcare professionals. But yeah, because there's 5 kind of levels from fully autonomous to complete control.
Thank you. Oh yeah, at the front. If you just introduce yourself, please. Thanks.
Hi, I'm Mark. I'm a consultant neurologist. If I could give you a magic wand, each of you, what that could do one thing, but only one thing, that would have made your life easier in what you've achieved so far, or what you want to achieve next, what would it be?
Should we start with you, Sophie, and go across? Great question.
Yeah, really good question, thank you. Just one. I think mine would be around the time it takes to innovate. Try and shorten that down. I also understand though, because it's patient safety and it's data, so there's a reason why it takes so long, but I feel like that is something that we can work towards in the future. Thank you.
And where do you think those that block without naming individuals or, you know, because they're not here to, no, but they're not here to defend themselves.
Right?
And, you know, it's a challenging time for all our colleagues out there. So it's not about that, but it's about how do we accelerate that timeline? Because you're absolutely right, that is.
Yeah, exactly. So some of the key barriers that I've come across is the vast amount of stakeholder engagement that's needed to implement. It does also depend on the product. So I'm right at the heart of acute secondary care. So understandably, I've got a lot. By stakeholder engagement, I just mean all the people I need to talk to say yes. Another part of that is governance and the clinical safety documentation. So CSO is a clinical safety officer. Sometimes the hospital only has one. And they have to authorise all the suppliers that are coming through. So I think maybe in time, and maybe it's a part of future research that I'd quite like to do. I don't know if it is done or not, but perhaps try and standardise that process or some kind of workflow or guideline that people can go to. It's one of the trusts we're engaged with. They're just so new to innovation, so it's a learning experience for them too. So I think there's something to be looked at there, I think.
Yeah. And for those of you involved in clinical trials, O'Shaughnessy has just written an independent report on the regulatory approval for clinical trial setup and things, which is challenged, let's put it that way. And so for those of you looking at the recommendations that have come out of the O'Shaughnessy report, it's certainly something I'm looking at, saying how can we get this innovation done, and they give case studies of the COVID research, which was set up absolutely, you know, in a gold standard way, you would argue. So why can't we now keep with that? So sorry to interject. Matimba? Magic wand?
Yeah, I mean, money's always good, right? But so I think it's kind of similar to Sophie, but time, because I think there is a demand for people to understand what researchers are doing, what developers are doing, but there's not always time to do this stakeholder interactions and stakeholder engagement. And I think engineers are definitely open to doing it, and computer scientists, but they don't have time. So it would be good to be able to have that time, like whether that's the university giving people time or something, but yeah.
And I think you might find you've got two willing participants over there, not wanting to speak for Stephen and Nigel, but I think I know them quite well. Rob?
I can grab the mic. Good question. I think from a patient point of view, I wish there was an AI that looked at my results and knew my normal ranges and then just told me when I needed to know. But from an NHS perspective, I guess going with the time theme, I'd wind back the clock to pre-MP fit. And I would have scoped that piece of work to be, don't care what system you use, but we mandate that you must provide an interface that gives a standard patient demographic record, a standard recent history record that can be queried from any trusted health provider. Because I'm on holiday in Cornwall later on tonight. If I need help, if Gloucestershire had a standard API that every health system recognised and I needed help, they could just go in, query, and I'd say, go and look at that organisation, query my record. They'd get the data back. I wouldn't have to convince them of anything. And care nationally and possibly internationally could be much improved with the right information in the right hands.
That was good delegation.
I mean, I think really being able to change the culture and behavior much quicker, I think that's what we need. It's not just going digital, it's going digital, but using it to change how we do things. I think that's the most important thing.
Yeah. And you're a breast surgeon by training, so we want you in the theatres, don't we?
Absolutely.
Operating.
Yes.
Yeah, absolutely. Dion, I'm going to put you on the spot. You were nodding when Rob was talking. Do you want to make a comment? Sure. I mean, this data is very close to your heart. Sorry to put you on the spot, but...
Yeah, no, I think I agree. I think I understand there needs to be safeguarding for data, but I also think we collect a lot of data and you don't actually get to see what's happening with it. So I think there's also the flip side for lots of people who are collecting all that data, like yourself, and then you can't actually pull it out and look at it. So I think there's just, what's happening in the system where you can't access it if you need to check something, but you also, if you're trying to help and analyze the data, you can't do it either. So I think there's got to be a conversation about how can we make it easier for people to use the data that we are collecting, that we're spending time, resource and money.
It's there.
It's there, but we can't do anything with it. And that's from lots of different sides. So I think that's where the conversation could go next. I think there's lots of different initiatives going on, but it's not the conversation. It's the, oh, let's try this new thing. But it's, people really have to come together and talk about what can we do now with the data we have to let people access it to do good. And I understand we have to make sure that people don't do bad with it, for lack of a better word. But I think there's a lot of people within the NHS and without that want to do work with what we have to make it better and improve it. And we're also, restricting that.
Yeah, thanks, Dawn. I knew you'd have a good answer, so thanks. Yeah. Oh yeah, Mark. Sorry. Are we done? Are we going on to the debate?
No, we still got 10 minutes.
All right.
Yeah. We've got patient advocates here. I'm going to be the virtual attendees advocates now because there's a very interesting question on here from Simon Chapman, who unfortunately couldn't come. He's a clinician who fellow clinician who codes, pediatric consultant, and been working with Marcus Bohr on the growth charts from the Royal College of Paediatricians. Very exciting stuff. He wanted to come and ask some questions at the debate later. Unfortunately, he couldn't be here, but he's got a very interesting question which is dear to my heart. Can I ask each of the panel how much of their code is open source?
Should we start this way?
Well, the code itself is not open source because we just use C#, which is the Microsoft product, and the database itself that uses SQL database. So again, it's not our own creation. So it is. If we, for example, install our product, it would be managed by an IT department. They don't need us to manage their database or to manage the code. But yeah, it is completely out there. It's not ours.
That's not an answer to the question. It doesn't answer the question. You're saying that it was because of C#. Well, you can open source C# code. So no, it's your code, your solution could easily be open sourced and used for it, but you need to protect your investment to be able to make money from it. But to say that it's delivered on SQL Server and on C#, that doesn't answer the question.
Well, I mean, we can't obviously just give away our code and not make any money out of it because we wouldn't be able to actually set aside the time.
Do you want to comment on this properly?
Yeah, no, that's fine. No, let's have Grant. Just introduce yourself, Grant. Yeah, this is the Zod, which is good.
So, hi, I'm Grant Valance, Department of Clinical Haematology's Information Manager, and evidently rather passionate advocate of free and open source software in the NHS. I was worrying about, we could end up starting debates early, but with due respect to innovators and for commercial companies, I am sick of our money paying for great innovation, but then having to keep paying for the innovation. Why don't we pay our money, our NHS resources, so that we have our own solutions which we can take on? And the point is, a lot of the stuff that we end up doing is co-development, and then we end up paying through the nose for sometimes very marginal improvement. I mean, take Lister, for example. Looks like a fantastic product, except it's backed by venture capital, which is going to want a return on the investment, and no doubt the innovators may not want to become unicorn billionaires, but they want to get somewhat rich. Yeah. Why aren't we doing the software development internally and releasing it as open source so that all the NHS can benefit from our own internal expertise and capabilities?
Thanks, Grant. Do you want to come back on that, please? Come on that. Yeah, come on back.
I actually led the going paperless in our department, and I worked with IT for about 3 years trying to develop something similar to this with programmers, and they were very, very clever C# programmers, and they worked for about 2 years, and we didn't actually manage to produce anything at all. We gave them all the resources that they need, the time, the everything that we wanted to create, and nobody came up with anything. And because of change of staff, After 2 years, the person who was in charge of that left, and somebody else retired, and the whole thing just came to a standstill. And there was no product at the end of 2 years. So
and you're an NHS clinician.
Absolutely. I work for the NHS, and I tried. It's not that I didn't try. So I did this in my own time, and with collaboration with Kareem and with other members, and we then managed to produce this.
Yeah. But, and I think this is an ongoing discussion, and we're going to maybe touch on this in the debate, but thanks for that. We're not, you know, we're all colleagues here, but we want to have these uncomfortable conversations. Rob, we're going to go that way.
Okay, so my view on open source is, yes, it's a great thing, and we should aim that way, and yes, if the NHS could get itself coordinated to build stuff, it should. The reality is there's market forces at play. So at the university, we use a virtual learning environment for all of our students called Moodle. It's open source, it's free. We struggle to get support on that as an open source product because the world isn't organised enough to create enough capacity for me to buy the support I need. So I need to develop my own. And the reason you end up in a model where everything gets commercialised is, number one, yes, or it's backed by a company that wants to make profit. But actually, that means that they can afford a support team. That means you can rely on them. So if we built it ourselves, or if we built it open source ourselves, we really need a central team that knows the product and can support it. Because the risk with open source is no one owns it. But there's no reason why you can't do that with the right agreements. I don't disagree, and wouldn't that be wonderful? Can the world get there? I don't know if it's our lifetime, but it would be great if it could.
Can I just...
Yeah, please come in at the back. Yeah, can you just introduce yourself?
Yes. Whatever you would press my microphone.
Sorry, I'm going to introduce myself. I did a PhD at university and then went into industry. I worked for HP, an IT company. And some of the software we produce is open source and some isn't.
Yeah.
And I think there's a misunderstanding for the gentleman here what open source means. Open source isn't meant to mean free. Open source means that what you develop, you're open to other people taking it and improving it and doing their own thing with it. And that's the real benefit of open source. That's why some of the big open source projects are so successful, because lots of people will contribute and make it better. And with open source doesn't mean you don't make money out of it. Some of our software is open source, and we make a lot of money out of it because we install it and we support it.
Yeah.
So just because it's open source doesn't mean everyone gets to use it for free and never has to pay anything. My point is that open source lets other people collaborate, and you can still make money out of it because it needs to be installed and supported.
Yeah, I mean, great point. I mean, I'm learning, so I think there's an ongoing conversation perhaps to continue. Matimba.
Yeah, so some in our lab, some of it is, some of it isn't, and I'm going to work with one of my colleagues on something where I want to look at like fault detection, and for that I would make that open source. But the biggest problem I think that we have is more open access with publications. So not all of our publications are open access. So I think that's actually a bigger issue.
Thanks, Matimba. Sophie.
I think it's a really good point. So sorry, I can't remember your name, but your point was the first step for me. One of my biggest challenges is that I never wanted to be an entrepreneur. The only reason I became an entrepreneur is because I felt like if I didn't do it, the problem wouldn't be solved. So the hospital that I worked with very politely and very understandably couldn't support me because they were procuring a very expensive EPR. So that's where all their tech resources went into, which didn't solve the problem. So I thought, okay, fine, no worries, I'll just carry on as a clinician. And then I'd go back to the wards 2 years later and I'm like, the problem's still there. So I didn't really have much of an option. I needed a product, I needed a team. So I did go down the VC route as a way of solving the problem. But I guess that would be my second magic wand, because I actually feel like if the NHS, and this is part of the role of the NHS Clinical Entrepreneur Programme, did work more collaboratively, because health industry leaders also want to make the NHS better too. They do have, it's not all about commercialisation from my experience with them, that actually a really good collaborative approach would be a great option in problem solving and working very closely with NHS clinicians to problem solve together. So yeah, I feel like it's probably going to be a combination of the two, I think is the most sensible.
And it's trying, you know, I can hear there's that real tension between you as a clinician and I've got to do something about this, and the only way to do in your field has been to do that. And I think that's a real tension, and I think that is something that, even though there's disagreement in the room, which is a good thing, we need to embrace that and say, the most important thing is that we affect change for our patients and our staff. And certainly the example you gave, I mean, to be doing that in 2023 with, the focus particularly on perimaternal, perinatal health. I mean, I think we can improve. So really, really, fascinating. I think, we've got 2 minutes. I think we'll close it there. Oh, Stephen, last word to you, and then we're going to go to the debate.
I spent a long time in the computer industry. In fact, the organisation I was with was the second biggest computer company in the world, is now part of HP. So I'm quite interested in that, and I've also continued to be involved in IT since then. And the whole thing of open source is really important because it means that you drive towards standards. And Rob was talking about standards of APIs, standards of interfaces, standards of how you structure databases, so that interoperability is there. And I think that's really important in all these things. Otherwise you get lots of tiny bespoke things which don't have legacy built in. You really need to build in the future-proofing of major pieces of work on which other things can then develop and go forward. That's what I was working on in digital, in how we develop the internet. Look at how these years later, we're still using it. This was in the 1980s. I first delivered my first project on the internet, 1986.
Who knows where we'll be in another 20 years.
And so, well before the World Wide Web. And this has been built around open source. And look how many people, organizations, use it in lots of different ways, and also how companies make profit out of it. Now, a lot of you will use websites built on the WordPress platform. WordPress is the most successful web design platform going. It's actually a management system for data. Now, WordPress is an open source software. There is a WordPress company which supplies WordPress-based hosted systems, but I can go in there and I can code, I can build my own interpretation on top of it. There are thousands of companies making, using WordPress open source and building on that. So this business of open source, I think, is really, I think something which the NHS really needs to get sorted and understand that there's a need to drive towards that.
Yeah, no, thanks, Stephen. I'm reminded of a conversation we had with Darren Atkinson, where in departments, and Sophie just alluded to this, that IT departments are quite rightly focusing on keeping the updates of those things, electronic records, e-prescribing, safety, and so there is very little time to look at those approvals and inputting into the innovation. And I think he moved to a department where they had two separate IT departments that could focus on business as usual and then what is coming, and ensuring that hopefully some of that acceleration you talked about is there. But I don't think that's replicated around, so that was potentially his solution. I don't think he's joining us this year, but we can put you in touch because he's certainly experienced that. So I think, Mark, what an amazing panel. Everyone's around all day. We're going to have lunch after the debate. So keep these conversations going. Really welcome everyone's input. And thanks very much. Amazing panel. Really learnt heaps.